Hello everyone. Today we will discuss that how does coronary artery disease present and how can you differentiate between angina and heart attack clinically. Once you will start your clinical practice, the most common calls you will receive from the wards or emergency will be about a patient complaining of chest pain. But not all chest pains are because of heart attack. This table will help you differentiate the main points between anginal and non-anginal chest pain. Anginal chest pain means when the pain is originating from the heart muscles when they're unable to receive the oxygen they require to work. But non-anginal pain is not cardiac in origin. Specifically, it is not due to coronary artery disease. It could be due to costochondritis, pneumonia, pericarditis, etc. First is the character of the pain. The patient will describe chest discomfort, which is like pressure, squeezing, constriction, choking, burning, tightness, or a knot in throat or chest. Whereas the non-anginal pain will be sharp, stabbing, or like pins and needles. The onset of anginal pain is gradual and constant, but non-anginal pain is not constant. It keeps changing with position or respiration. Also, the anginal pain is diffuse over the chest. It is mainly central. However, if the pain is non-anginal, then the patient can actually point at a specific spot. Pain due to coronary artery disease will be aggravated in situations where heart muscles require more oxygen, like during exercise. But the non-anginal pain can be aggravated by the movement of arm or trunk, like in cervical spondylosis, or bending forward, like in pericarditis. In terms of duration of pain, the anginal pain lasts about 2 to 5 minutes, but the non-anginal pain will be either less than 5 seconds or more than 30 minutes. The anginal pain radiates to the back, shoulders, arm, neck, or jaw. Non-anginal pain does not usually radiate to these areas. Sometimes a patient might tell you that they have chest pain and arm pain, but you have to make sure if the chest pain is radiating to the arm or it is the arm pain that is eliciting the chest pain, which is not a sign of anginal pain. When you press on the chest, in the anginal pain, it will be non-tender. But if it increases on palpation, like there is tenderness when you palpate the chest, then it is a non-anginal pain. There are some other symptoms associated with anginal pain, like shortness of breath, nausea, and profuse sweating. These symptoms are usually absent with non-anginal pain, but they might be present as well. Lastly, the anginal pain can be relieved by GTN, which is glycerol trinitrate. It is given sublingually and it is a vasodilator, so it helps relieve the symptoms temporarily. But the non-anginal pain may or may not be relieved by GTN. In fact, it can improve by lying down or other painkillers like NSAIDs. In summary, NICE defines anginal pain as the following: constricting discomfort in front of the chest or in the neck, shoulders, jaw, or arms, precipitated by physical exertion, and relieved by rest or GTN in about 5 minutes. Patients who have all these 3 features have typical angina. Patients with 2 of the above features have atypical angina. That means that it might be angina, it might not be angina. And patients with 1 or none of the above features have non-anginal chest pain. Once you have established that the patient has anginal pain, then you have to diagnose whether it is stable angina, unstable angina, or myocardial infarction, that is heart attack, because the treatment differs. Stable angina is usually on exertion. The pain is there for more than a month, and it is relieved by stopping any physical exertion and by taking GTN. Cardiac enzymes, specifically troponin, is negative, and ECG is often normal. Such patients can be discharged safely on antiplatelets like aspirin and they can be treated in the outpatient department for the risk factors of coronary artery disease like hypertension, diabetes, and they should be investigated further, such as by CT coronary angiography. The unstable angina, or MI, are more serious conditions. Unstable angina can progress to MI very quickly, so these patients should definitely be admitted in the hospital and treated accordingly. Unstable angina occurs at rest. The onset is recent, that is less than a month. It may or may not be relieved by glycerol trinitrate. Initially, the cardiac enzymes and ECG are normal in unstable angina, but as I said, that it can quickly progress to MI, so it is essential to admit the patients for treatment and observation. If the patient has MI, then the cardiac enzymes will be raised, specifically troponin, and there will be ECG changes like ST segment depression or elevation, ischemic T wave changes, etc. That's it for today. In the coming lectures, we will talk about management of coronary artery disease. If you like this video, then don't forget to share it with your friends. Take care and God bless you all.